Dr. Juhi ARORA. She will be presenting a case of Crouzon syndrome. We also have Dr. Akansha Bapnore. I'll ask that person is okay. You're ready, right? Next, we'll have your presentation.
Good afternoon, everyone. I'm presenting a case of Crouzon syndrome. Crouzon syndrome is a genetically inherited autosomal dominant disorder, second most common craniosynostosis syndrome. First described by a French physician in 1912, Octave Crouzon, originally called it as craniofacial dysostosis. Crouzon syndrome is diverse in clinical presentation due to variability in craniosynostosis. The diagnosis may be missed in milder phenotypes and are thus prone for misdiagnosis. Gain of function mutation of fibroblast growth factor receptor 2 and 3 on chromosome 10 causes accelerated osteoblast differentiation, resulting in premature fusion of skull sutures. A 2-year-old male reported with chief complaint of bulging of both the eyes since the age of 9 months. There's no history of visual symptoms, any misalignment of the eyes or poor vision, no history of foreign body sensation or redness in the eye suggestive of exposure keratitis, no history of seizures or mental retardation or hearing loss. The prenatal, delivery, and the postnatal history was found to be insignificant. Family history: non-consanguineous marriage, one sibling, elder sister not affected. He is the second child, mother affected in milder form. Father and grandparents are not affected. Rest of the skeleton system was within normal limit. Developmental milestones are appropriate for the age. Examination: the baby was not cooperative for visual acuity evaluation, but refraction was done -1 diopter spherical in right eye, -0.5 diopter spherical in left eye. Frontal bossing, asymmetrical skull growth, increased intercanthal distance suggesting telecanthus 33 mm, and depressed nasal bridge with low set ears were present. Pupillary reaction, direct and consensual, both were present. Both eye, upper lid more than lower lid retraction present. On Hertel's exophthalmometry, right eye 21 mm, left eye 22 mm. Ocular mobility revealed intermittent exotrophy of 20 prism diopter with good control with V pattern and primary inferior oblique overaction. No lag of thalmos, no lid lag, and no signs of exposure keratitis. NLD passages within normal limit. Anterior segment within normal limit. Fundus no dyspallor extorsion. This is a picture of the baby showing upper and lower lid retraction, and mother picture showing unilateral lid retraction. Video of the baby showing intermittent exotrophia and X-ray skull showing fusion of metopic suture. Craniosynostosis syndromes may take time to manifest and therefore may be missed in early childhood. It is inherited as autosomal dominant fashion, but there is equal incidence of sporadic cases representing new mutations. The present case highlights this clinical dilemma: frontal bossing, misshapen calvaria, telecanthus, bilateral upper and lower lid retraction, along with V pattern intermittent exotrophia, highly suggestive of Crouzon syndrome. Hence, we report a milder phenotype, which may end up with wrong diagnosis. In the presence of bilateral upper and lower lid retraction, V pattern exotrophia, primary inferior oblique, common craniosynostosis syndrome like Crouzon should be suspected and evaluated by other clinical parameters and imaging. Within the family, members tend to have similar facial deformities but variable calvarial deformities, and this phenotypic heterogeneity makes it difficult to diagnose. The differential diagnosis may include thyroid eye disease, primary congenital upper eyelid retraction, dorsal midbrain syndrome, Apert syndrome, and orbital mass and tumors. In pediatric age groups, subtle forms may be missed or misdiagnosed. As a child grows, the typical features of Crouzon may appear and present with sight-threatening problems, so an early diagnosis is crucial. Thank you.
So, like in your case also, the differential diagnosis is orbital tumors. Did you imagine that patient?
So, but
simple, very simple thing. That is what I said in the initial phase also. Every orbital or anything you have to image and come to some conclusion. Textbook teaching is different. You yourself is saying, go back to that differential diagnosis. Look, you yourself is writing that orbital masses, orbital tumors is the differential diagnosis, isn't it? And that they need congenital malformations. Fine, you may treat, you may not treat. But orbital tumors, orbital inflammatory diseases, thyroid eye disease, you need to treat them, and you have not worked this case up.
But sir, the mother was also
having... It is not but or if. You just look at the last of this. orbital tumors, orbital inflammation is one of the differential diagnoses, and you have not ruled them out. And they need, if it is there, it needs a treatment. Otherwise, this child may not need any active intervention, isn't it? If the cornea is okay and accept the cosmetic treatment. So, working up of a patient, especially of any orbital disorder, proper workup has to be there before you proceed further.
Thank you. Just one question. What is ureblefron? You have any idea? What is ureblefron?
It is decrease in the
Decrease.
increase in the
So did your patient
palpable
have
fluid.
it? Have you seen any patient of ureblefron previously?
No, sir.
This is exactly a case of ureblefron. So the horizontal as well as the vertical palpebral aperture increases. It's typically seen in Crouzon. So just, I think you did not mention it in the signs and symptoms, so you just keep it in your mind.
Thank you.
So basically what, all through, it was quite evident that this is a craniosynostosis, but then, sometimes these imaging measures, they help you exactly what is the gravity of your, problem. Are you missing out on something? So one, I understand you are exposing the child to radiation. So sometimes we think why to, get a CT done. But at times it is, if you're in doubt about anything, it is better to get a imaging done and take your measurements properly. That's all. Thank you.